All right, picture this. The alarms are screaming in the ER, your patient is crashing, and you've got seconds, not minutes, to act. You're on the front line. You need a plan. And today, that's exactly what we're going to break down, the life-saving protocol for acute heart failure.
This isn't just a dramatic turn of phrase. It's the terrifying reality for someone in acute decompensated heart failure. Their heart just can't pump hard enough, so fluid is backing up and flooding their lungs. It is a true life-or-death medical emergency.
So, the patient is right there in front of you. They are panicked, they're gasping for air, their skin is starting to turn a scary shade of blue. What do you do? Right now, the clock is absolutely ticking.
Okay, let's paint the full picture here. We've got a 65-year-old man, he's just been wheeled in, and he's fighting for every single breath. He's sweating, he looks terrified, and you can see that telltale cyanosis, that bluish tint to his skin telling you he's starved for oxygen.
You know, in medicine, things can be murky, but not this. This classic presentation points straight to one thing: acute decompensated heart failure. And thankfully, there's a powerful, clear-as-day protocol to get things under control. LMNOP. This is your lifeline.
Now, this mnemonic, LMNOP, it's not just something you memorize for a test. It's a real-world framework for taking fast, decisive action that saves lives. So let's break down what each letter stands for and how it works to pull this patient back from the brink.
Here it is: Lasix, morphine, nitrates, oxygen, and position. Those are our 5 big interventions. But we're not going to go in alphabetical order. We're going to tackle them in the order that actually makes sense in the middle of a crisis.
Before you even reach for a single drug, you have to fix the most immediate problem. The patient can't breathe. So the first things you do are O for oxygen and P for position. You get a mask on them and you sit them bolt upright, letting their legs dangle off the side of the bed. It's brilliant. It costs nothing, it works instantly, and it uses gravity to pull all that fluid down and away from the lungs. They can breathe easier, just like that.
Okay, they're sitting up, they're getting oxygen, now we can bring in the meds. First up is L for Lasix, which is the brand name for a drug called furosemide. And we're giving this IV because we need it to work fast.
Now here's the really cool part about Lasix, and why it's such a superstar in this situation. Yeah, we all know it's a diuretic. It makes you pee out all that extra fluid. But that takes a little while to kick in. The magic is what it does instantly. It acts as a venodilator. It relaxes the veins, which immediately reduces how much blood is rushing back to the heart. It gives that poor, overwhelmed pump a break, right when it needs it most.
To build on that effect, our next tool is N for nitrates. We're usually talking about nitroglycerin here. This is another absolute powerhouse in our toolkit.
So why nitrates? Well, it all comes down to a concept called preload. Think of your heart like a water balloon. Preload is how much you stretch that balloon with water right before you squeeze it. In heart failure, that balloon is stretched to its limit, totally flooded. Nitrates are amazing venodilators. They open up the veins all over your body, creating a whole lot more space for blood to hang out. That means less blood rushes back to the heart, which dramatically reduces that stretch, that preload.
Okay, so we've got L, N, O, and P down. That just leaves M for morphine. And this is where things get a little tricky, because in modern medicine, the use of morphine has become pretty controversial. Back in the day, morphine was a go-to, and you can see why. It's fantastic for calming a terrified patient down, which in itself reduces the stress on the heart. It also helps dilate blood vessels a bit. But, and this is a huge but, it can also suppress the drive to breathe. For someone who's already struggling for air, that is incredibly dangerous. So while you still need to know it for your exams, in real life, you'll see morphine used very, very carefully, if at all.
Look, knowing what to do is half the battle. Knowing what not to do, well, that can be the difference between a patient living and dying. And there is one class of drugs you must absolutely, positively stay away from in this acute phase.
Let me say that again, just so it sinks in. Do not give beta blockers to a patient in acute decompensated heart failure. Now, this is tricky because beta blockers are a key part of managing chronic heart failure. But right now, in this acute crisis, giving them could be catastrophic. They slow the heart down. Giving that to a heart that is already failing could literally cause it to stop pumping altogether.
So here's a great little phrase to burn into your memory. If the patient is wet, meaning they're full of fluid, and wild, meaning they're acutely crashing and unstable, then there are no beta blockers. You stop them if the patient is already taking them, and you don't even think about starting them again until that patient is stable and dry.
So, let's say you've done it. You've run the LMNOP protocol.
The patient's breathing is finally starting to ease up. The panic is subsiding. The immediate crisis is starting to pass. Now our focus shifts from this frantic rescue to stabilization and figuring out what's next.
But as things calm down, there's one specific type of patient you have to be on high alert for: the cold and wet patient. This is someone who is not only fluid overloaded or wet, but their hands and feet are cold and their blood pressure is low. That is a very, very bad sign.
A cold and wet patient is telling you they're probably tipping over into cardiogenic shock. That means the heart pump is failing so badly it can't get enough blood out to the rest of the body. For these patients, LMNOP just isn't enough. They need to go straight to the ICU for more powerful support, like Inotropes. These are drugs like dobutamine that literally help squeeze the heart and make it contract more forcefully.
And you know, all this talk about evolving practice brings us to our question of the day. We're really curious what you're seeing out there. In your hospital, in your clinical practice, is morphine still part of the initial game plan for acute heart failure, or has it been pretty much replaced by other options? Let us know what you're seeing.
So, we've navigated the storm. We've pulled the patient through the acute crisis. They can breathe again, which is a huge win, but the fight is far from over. The question now is, how do we keep them alive for the long run? Getting the water out was step one. The real challenge is fixing the pump for good, and that's where a whole different set of medications, often called the Fantastic Four, come into play. But that is a story for another time.